Now we have Dr. Dalia talking to us on soft contact lens fitting. Dr. Dalia is a senior teaching faculty at LIP Medical College.
So my topic today is soft contact lens fitting. So whenever a patient comes to us for a contact lens fitting, we have to see into many factors before we order for a contact lens for the patient. So scan in the slit lamp, the patient has to be scanned throughout for any abnormalities which may hinder contact lens use. You have to scan from the temporal to the medial side. The lid has to be, whether there is any evidence of any lid abnormalities, the conjunctiva. Then you properly see a refraction, a subjective and objective refraction has to be seen for the patient. When you do a subjective and objective refraction, you can also get the keratometry values, which are important to know the total diameter of the lens. Confirm it by the objective refraction, retinoscopy has to be done. And with all this, a subjective refraction with the patient has to be done. The trial lens has to be done and see whether the patient is comfortable with the uniocularly, binocularly, and also whether the patient is comfortable for near work also. This is the subjective refraction being done with the patient. Now for the measurements which have to be made is the horizontal visible iris diameter. So which is the patient has to be in the primary gaze. This is the horizontal visible iris diameter, which is measured either with a caliper or a millimeter scale also is useful. The palpebral fissure height has to be measured. If there is an increase in the palpebral fissure height, a large contact lens has to be ordered. Horizontal visible iris diameter plus 2 millimeter will be your total diameter of the lens. Now, Schirmer test to evaluate whether there is any dry eye. T-BUT has also to be done for the patient. Now, these are the measurements. Then record all the measurements. You have the keratometry values. So, average keratometry values will help you to find out the base curve of the lens. The horizontal visible iris diameter plus 2 millimeter will be your total diameter of the lens. Palpebral fissure height, the subjective refraction. It's not working. So this is all the recordings which are to be made. Now the total diameter, all the recordings which have to be recorded for the patient. The power of the contact lens from the subjective refraction. So the spectacle power divided by minus the back vertex distance has also been checked to know the power of the contact lens. Moving. Now the contact lens being placed with a trial lens, you can use this. Here the refraction of the patient was -2 diopters, but this is done with a -1 diopter contact lens. You insert the contact lens and see whether the patient is comfortable. Ask the patient to move along. See whether the patient is comfortable and look for the centration of the contact lens. So you can see the coverage of the contact lens that should be adequate all around. The movement when the patient is moving on all sides, the movement should be adequate. It should not very freely move because that will be, if it's a larger diameter lens, it might move too much. Now this is a push-up test. What you are doing, the lower edge of the contact lens is just pushed up and see whether it is freely coming back down. This has to be also to be done. When it is very freely moving, that will go off otherwise. Now this is over refraction being done because it was a trial lens with -1 diopter and the refraction was -2. If it's the same power what you are using for it, you don't have to do a over refraction, but here the over refraction is also done with the -1 contact lens and -1 is the over refraction being done. And this is the final prescription which has to go. See, there is a good centration, good coverage, the patient is comfortable, optimum movements. Since there is a little more lag, the base curve has to be increased. The final prescription should also be given to the when you are dispensing the contact lens. So accordingly, the trial what you have done, you can modify the prescriptions. If it's an optimal fit, no modification is required. Steep fit, you order for a flatter base curve, and a flat fit, a steeper base curve can also be ordered. Thank you.
Very nice, Dr. Dalia. Yeah, soft contact lens, even though we all practice, a lot of small things I think which are very relevant. And as she rightly said, the lens should be centered well, moving when you are blinking a little. And you should also observe under the slit lamp whether any blood vessels at the limbus are being pinched by the contact lens. That is one thing. And then you check for the visual acuity. Visual acuity, you check for distance. You ask the patient to blink, and see whether the vision continues to remain stable during the blink also, after the blink. If it is not stable after the blink, it is loose. That is one thing that is one idea that you will get, and immediately you will try to change the base curve. Second thing is, whenever you do over refract, fog the other eye so that the patient doesn't accommodate. That is one. And then near vision you should always check. That is one thing I feel. Any patient you are giving, particularly for myopia, always check the near visual acuity with contact lenses. And otherwise, it was a very excellent presentation. Very useful one also for practice. And please remember to give a handout to the patient and explain to the patient how to handle soft contact lenses. 2 weeks it will take for them to learn how to handle contact lenses. They will learn insertion and removal is absolutely easy. They will learn it in 2 weeks' time. But hygiene of the contact lens is extremely important. I have seen one of my patients who was an MBBS student, long time, this was 22 years back, a Malaysian student, came in, had severe conjunctivitis. I said, let me see your contact lens and the case. She put her hands into her jeans pocket and took out the lens, not the case. And so I think teaching the patient hygiene is absolutely important. Thank you. So who is next?